the idea of giving intraoperative radiotherapy is now 25 years old. So at that time, the data from our laboratory work, as well as from clinical trials, suggested that when you treat breast cancer with a lumpectomy and radiotherapy, which is what most cancers can be treated with, radiotherapy is given to the whole breast. And this requires patients to travel daily to the hospital for 3 to 6 weeks. This actually makes many women say, well, no, just do a mastectomy. I can't do this traveling. I can't stay in the metropolis for so long, and so on and so forth. That was the clinical problem. And biologically and in terms of the nature of breast cancer itself, we found that local recurrence after breast cancer operation and radiotherapy is not very common, but when it happens, it seems to happen mainly around the tumor. So why radiate the whole breast? This was our thought. We developed a new device. So we developed a new device and a new operation. We call the operation Targeted Intraoperative Radiotherapy. So short form for that is TARGET, or TARGIT-IORT. In order to test whether this works or not, we devised a large clinical trial called TARGIT-A trial. So the new idea was to give radiotherapy to only the tissues around the primary cancer after it was excised, and give it immediately after it was excised, so that there are two main principles: precision, or giving it to the right place and at the right time. So this was the TARGIT-A trial. This trial was started in year 2000. So now we have a real long follow-up which is really required for breast cancer outcomes. And these results were published in the British Medical Journal last year, and in the Nature publications, British Journal of Cancer earlier this year. And the new data with very long follow-up has now shown that giving such radiation, risk-adapted TARGIT-IORT, actually yields breast cancer outcomes which were as good as standard whole breast radiotherapy. So the chance of remaining free of cancer in the breast, free of cancer elsewhere in the body, the chance of remaining preserving the breast, and chance of surviving from breast cancer were all the same, whether you gave radiotherapy during surgery as risk-adapted approach or whole breast radiotherapy. So this is great news, but there is even more bonus. One is that we found, while the breast cancer deaths were the same, deaths from other causes, such as cardiovascular causes, lung problems, and other cancers were significantly and substantially reduced by about 4.5% at 12 years. So this is really a big amount. And this means that for patients with grade 1 and 2 cancers, there is an overall survival benefit of between 4 and 5%. Now, to put this in perspective, the benefit that you see patients with breast cancer of similar type receive by giving the drug trastuzumab, or Herceptin, as you may know it. It's a very expensive drug, requires treatment for nearly a year, and can damage the heart. The benefit from this treatment to breast cancer patients who are less than 2 centimeters NER positive is actually just 4%. So it is a similar benefit that you would get by giving radiotherapy during surgery, that is TARGIT-IORT, which costs less, protects the heart, and is good for the environment. So this is particularly important in this week, when we have COP26 going on. The amount of environmental benefit of TARGIT-IORT is it would save in the UK 5 million miles of travel, 170,000 women hours, 1,200 tons of carbon dioxide, which requires a forest of 100 hectares annually. And in short, there are 900 fewer deaths annually if we adopt TARGIT-IORT, and it will save NHS £9 million every year. So it is a win-win situation for the NHS and for the patients. So we should make it available in every place where breast cancer is operated. In the latest paper, we have found that if local recurrence occurs after having received whole breast radiotherapy, conventional whole breast radiotherapy, it actually means that the patient has poorer prognosis. However, a local recurrence after having received TARGIT-IORT does not have poor prognosis, and their prognosis of patients after this is excellent, as good as not having any local recurrence. The other new finding is that in addition to avoidance of scattered irradiation leading to fewer deaths from other causes, it appears that TARGIT-IORT given during lumpectomy procedure has an abscopal effect, that is an effect away from the main site of giving radiation, which seems to have benefit in terms of reducing deaths from cardiovascular causes, lung problems, and other cancers. And this abscopal effect has been studied more and more in the last decade or so, and it is a real effect. It has been seen in other parts of the body and in other studies as well. Giving radiotherapy during the lumpectomy procedure for breast cancer with TARGIT-IORT is better for patients because not only do they finish their local treatment in one sitting in 80% of cases, it produces less pain than standard radiotherapy. It has better cosmetic outcome and improved quality of life, in addition to having fewer deaths from other causes, leading to improved overall survival in those with invasive ductal carcinoma and grade 1 and 2 cancers. And it is cheaper for the patient to not have to go to travel every day for this time, and saving their time as well as money for traveling. And it is cheaper for the NHS. This treatment is well recognized around the world, and over 260 centers in 38 countries have adopted this TARGIT-IORT as standard of care, so that over the last several years, 45,000 women have already been treated with this. So it's been adopted all over the world. It has been recommended by NICE in 2018, but we need to accelerate its adoption in this country in every hospital. And that is really important for NHS England and NICE to push, and NCRI to push really strongly.